I'm Larry Latour. I'm an imaging scientist. My background's in basic science, but I've been working in clinical research now for on the order of 20 years or so. And it's a great opportunity because it helps, one of the things that's very rewarding to me is developing the technology and the science, for me at least as an engineer and a basic scientist, that really has the potential, I think, to impact patients, at least in my lifetime and maybe even during the lifetime of a postbac or a summer student. So I'm going to go over a number of different things. It was meant sort of to be interactive. So I'll ask you guys some questions. Hopefully you've had enough imaging now to be able to answer some of them. But I want to talk a bit about sort of a little bit of philosophical approach on science, because one of the unique things I think about, it's not unique, but one of the special aspects of the NIH intramural program is we can ask questions that gets very difficult to get funded for. Because most of what's done for grants has to be driven by specific hypotheses when you write the grant, and which is fantastic. It's the right way to do science, but it also isn't probably the best way to encourage discovery. Things that we really don't quite yet know what question to ask or how to ask the question the right way. And this is how I came about science as essentially a postbac between undergrad and grad school. And it was an oil exploration. I was about 21, 22, and I hadn't done science, I'd done engineering, and we were looking at how water moves around, how water diffuses in porous rock. And oil in the ground sits in porous sandstone or shale. And what we were using was, at the time, fMRI, to make measurements of how water diffuses. And the idea is that water in these pores, if it diffuses a long distance, it means it's a large pore. And when it hits the edge of the pore, the grain of the sand, the water relaxes by T1 and T2 relaxation. If you've been to any of these other presentations, you should now start get a feeling for what T1 and T2 is. And so this gets exciting because you make if the relaxation time constant T1 or T2 is very long in a rock, then the water is very free and there's a lot of oil, and it's easy to get the oil out. And so that was sort of the thought from an engineering standpoint. But the problem was when water moves, it's diffusing because of heat. And in the oil well, it's very, very hot. And can you guys guess what happens if water is diffusing faster? Does it encounter the wall slower, fewer times, more often? It encounters it more frequently, right? And so when the water hits the pore, you can think of it randomly diffusing in this pore space, like this room, and bouncing into obstacles like these chairs. If you heat it up, the water hits the walls and the obstacles more often. So that would cause relaxation to happen more frequently. So the hypothesis is, if you've phrased it in a hypothesis is, as temperature goes up, the relaxation time constant goes down. And that's a big deal. So I was given sort of the assignment of testing that. And what we found when we heated the water up until like 200 degrees C, where it's boiling, so it has to be under pressure, it didn't happen. Nothing moved. So the relaxation time constant didn't change. And, I'm a student. I'm like, yeah, okay, so they don't change. And, my advisor at the time was like, basically this is a discovery. We don't understand why this is. And that's what gets thrilling, is when we don't understand why something is. And we can't predict this. All right? You can't predict things that you don't really understand where it's coming from yet until you have a chance to observe it for the first time. And so I want to sort of bring that in because from early in my career, I was mentored in a way that to keep your eyes open for things and make sure you're asking the right questions and not close your mind. So this is a paper that's actually a really well-cited paper by a good author. She's a very good scientist, and it's about diffusion tensor imaging, which I hear some people are interested in mild traumatic brain injury. And you look at this is what has pushed our field in TBI, is this concept that axons are injured because of the mechanical shearing forces inside the brain when the head hits something and the brain moves inside the cranium. And what ends up happening is, presumably in this type of research, there's a change in some of the measures, the MR measures, like the apparent diffusion coefficient, which is a measure of how fast water can diffuse, or something that's called fractional anisotropy, which is a measure of how well water diffuses in one direction compared to the other directions. And this is how a study is typically set up. There's a selection of patients that have a diagnosis of TBI, right? And you find a control set. And nearly all the experiments that we do here even at the NIH is based on that same sort of paradigm. You find an injury group, and then you find a control group, and you match them as best as you can. And then you compare them, and you find that there's a difference between them. And if you look at the mild TBI group, they have a higher fractional anisotropy than the control group. You can say something about the radial diffusivity, the ADC, apparent diffusion coefficient, and you can see there's differences in these groups, right? So what do you make from this? What's the conclusion you draw from this? What's the important question we should be asking with regards to mild TBI? Why would this be important? Anyone want to throw a couple thoughts out there before I go on? Is it because we want to identify patients, diagnose patients that have TBI, that have injury in their brain? What are we trying to get at with this? So yes, absolutely. So one of the issues with mild TBI is we really don't understand who has mild TBI. Or have any of you, if you're concerned about raising a hand, please don't, but have any of you guys suffered a concussion? If you think about this. Yeah, somebody does. I know, of course. I have. Do you consider yourself to have mild TBI? Has your brain been injured? Are you a different person because you've had this concussion? So these labels that we assign to disease, that we assign to something that is very broad, have importance. And it's a little bit naive to think that mild TBI is the same as it is in him, as it is in me, as in any of you. It's a very diverse injury, and it's important to come up with objective ways to sort of stratify that. So I'm going to switch gears very frequently in this, and you guys guide me as what you find interesting. This is in contrast to what we do right now with stroke. TBI, I feel, is where we were with stroke 20 years ago. And this is what our team looks like, or how we image patients at our hospital. So we run the acute stroke service at 2 hospitals, one across Old Georgetown, one down in DC, just north of the Capitol, Washington Hospital Center. And patients that come into these emergency rooms, they either come in by ambulance or they're brought in by helicopter. A code is called, and our team responds, a group of neurologists. And our focus is on MRI in these patients within minutes of them making it to the hospital. So we image them. And these imaging sequences that are all up here did not happen instantaneously. They were developed over time because of the sensitivity and specificity of findings in an individual. So I'll walk through stroke. T2 star GRE, this is similar to what's used in BOLD, but it's a higher resolution sequence, so it's sensitive to changes in magnetic susceptibility. So what we're seeing on this particular scan here, besides susceptibility artifact around here, is this little guy right here, and it's an acute thrombus that's likely moved from the heart because of cardiovascular disease, maybe atrial fibrillation, and the clot's moved up and it's lodged in one of the intracranial vessels here. So this is the thrombus, the interluminal thrombus. This is a time-of-flight magnetic resonance angiogram, an MRA, and you can see the middle cerebral artery here. And if you guys are heading to med school, I'm going to pimp you guys a little bit on some of these questions. So you see the MCA here, and on this side you see a cutoff. The MCA drops off, so it's exactly at the place that the thrombus is. The same sequence on the same patient, at the same time, higher, more superior slice. This is a GRE, and you can see the vessels are maximally dilated both on the surface and in the deep venous structures in the white matter. So there's dilation of the vessels to increase blood flow. Hyperintense vessels are seen on FLAIR, but what's important is we don't see any of the lesion on a T2 FLAIR image, which would reflect either infarction, chronic ischemia, which is dead tissue infarction, or edema. This is, these 2 scans are from a bolus injection of contrast agent. So these patients have an 18-gauge needle in the anticube of their vein, and we inject gadolinium contrast agent, a couple different gadolinium contrast agents, at 5 cc's a second, and we run a BOLD sequence, a T2 star-weighted sequence dynamically, once every second, and then we watch the contrast wash through the brain and then parameterize those curves into something that's effectively like a CBF map, and something that has to do with arrival time. So you can see the whole territory, the MCA territory is involved because of this thrombus here, and cerebral blood flow is longer, and the arrival time, or the mean transit time of that contrast CBF is lower, is longer in this image. And then here's the apparent diffusion coefficient map. Healthy tissue has a diffusion coefficient of about 0.8. Cerebral spinal fluid has a value of 3.0 times 10 to the minus 5 centimeters squared per second. And then ischemic tissue, analogous to the porous media rock, when cells depolarize because of failure of energy, ATPase pumps, salts can't be removed from the cells, and the cells swell very quickly. And it's called cytotoxic edema. And you can think of these cells swelling. If I can walk away from the microphone for a bit, there's a microphone here. The cells in here, and because they swell, they cut off the extracellular space. Water can't diffuse as far as it would. Very analogous to the way we think about water diffusing in the porous media. So the cellular depolarization results in water not actually diffusing slower, not being able to diffuse as far, and that gets reflected on this map. And then the qualitative view, and I've chosen this one purposefully because there's a lot of motion, and blinded to any of this, you can still pick out the effect of the change in the parent diffusion coefficient on the diffusion weighted image. So here we have something that is representative of a number of things. A proximal target, something we can go after. What do you think is the best therapy for stroke if you were going to try to treat somebody with acute stroke? An acute stroke is a blockage in the vessel. Give you a hint. You want me to throw it out there? Thrombolytics, a chemical agent to break up the clot. Perfect. That was approved in 1995. It is, unfortunately, the old way of thinking about it now. We're trying to, as a group, figure out how to handle the new way, which is actually going in there mechanically and pulling out the clot with a mechanical device that gets in there exactly at this spot and pulls it out and reperfuses that tissue. But we have a target, we have a way to measure the effect of our therapy on that target, and we have a measure of how much it affects the perfusion in the tissue, whether or not there's these hyperintense vessels, which we think has to do with collateralization, whether it affects autoregulation, whether it affects cellular depolarization. All makes sense, roughly? And this is just sort of a sign out for our team, and I think for medical students, it's worth looking at because it describes how an acute stroke neurologist thinks about a patient and how they sign off to the next team. And this happens for us 24/7, all year round. And it's a group made up of attending neurologists, clinical fellows, MRI techs. It's a very broad group. And for me as an engineer, it's fantastic because it makes me feel like I'm having an impact on patients. And it's exactly what I want to get after. And so in order to do this, to be able to study these types of diseases or injuries, stroke or TBI, we could draft individual protocols or individual studies with hypotheses like Liz Wild's about the change in fractional anisotropy in TBI. That's one approach. Another is to have a very broad observational study, which we call our natural history studies. This is how our patients run through. We've screened over 17 years, 14,000 patients. Of those, all this is overhead for our team to work 24/7. Of the patients we see, roughly only half of them actually have stroke. And then it starts heading down to those that we enroll in our protocol, those that have a more severe stroke, NIH stroke scale score greater than 3, that's considered a disabling deficit, and those that we treat with a thrombolytic, which up until now is the standard of care and the most effective way to treat these patients. TBI, sort of similar. We screen a lot of patients. We approach a lot of those when we can. We can't run 24/7, and we enroll only a small fraction of them. But this is the population we need to address, not the ones that we know have TBI and those that we have a controlled population where we know that they don't have TBI. We want to know the patient that comes into the emergency room that is suspected to have a stroke. Do they have a stroke? And how can we better diagnose that? And how can we better stratify them? And the same thing's true with TBI. So I'm going to run through a basic imaging primer because you guys have already had imaging, most of you. If anybody wants to interrupt me, please do so. Sagittal, axial, coronal planes. There's a few things I want to point out which sort of go sometimes missed in the beginning, even if you've been doing imaging for a while. For what we do in MRI, we're selecting volume slices like this, sort of a slice of bread. And it has thickness. So we're not looking just at pixels, we're looking at volume elements. And these volume elements have a lot of heterogeneity in them, right? So they're big. They're big in the scale of cells. So we're not including any one type of cell. We're not including just white matter. We're not including just gray matter. Sometimes we are as we get to higher resolutions. Typically, DTI voxels or bold voxels are on the order of 2 by 2 by 2 or 3, something like that. That's a lot of tissue. And so we have to keep that in mind. So here's a typical DTI scan. It's the trace-weighted diffusion image. And this is the typical size of voxels in one of these scans. And this is the same, this is a 3x3 voxel. And this is the same brain, human, imaged at 7 Tesla with an order of magnitude higher resolution. And you can see the tissue is much more complex. So you feel really good. I mean, I feel good about myself as an engineer while I'm getting these higher resolution, but it's all relative. So you take a TBI brain, you image it, we see something where we have a change in susceptibility, which we think is related to bleeding around vessels, and I'll get more into that. And then when the patient dies, you cut the brain open and you stain it for iron, and then you find that the iron's in macrophages, but we're now another 2 orders of magnitude lower. So part of what we do in imaging is finding something, hopefully, that's happening at the pathological level, a level of pathology, where water's diffusing slowly because of cellular depolarization or because of iron is accumulating in macrophages around the outside of a vessel. And we use the imaging technique MRI, T2 star weight MRI, to accentuate that effect, or bold, for instance, for functional imaging, so that we're able to visualize it on a level that we can do it non-invasively, so we don't have to extract the brain from each patient to be able to see this. Does that make sense, roughly? Getting to sort of the thought? Okay, so this is my pre-dementia reminder. Okay, so I bring up a CT scan. So this is it's a horrible word to use, but called a dry CT, or it's a head CT without contrast, of a patient that has a stroke. And CT scans are exceptionally good at detecting blood, hemorrhage, in both stroke and TBI patients, but they're not good for looking at the cellular depolarization, the energy store failure that we lost because of the change in blood flow and delivery of glucose. So the only thing that I can see on the scan that looks like it could be suggestive of a stroke is this little dot that's right here that from a radiology perspective, a clinician's perspective, is referred to as a hyperdense MCA sign. It may or may not be. It's not as specific as what I've shown you on those other scans, but it's very easy to get a CT scan, and it's a standard of care. Because if a patient has a hemorrhage, we do not want to give them a thrombolytic, which could result in further bleeding. So the main purpose is to rule out hemorrhage in these patients. But while I'm looking at a CT scan, do you know what's given the contrast in this? Have you guys seen any CT scans yet in this imaging course? A little bit? So it's an X-ray, right? Shining X-ray from one side to a detector on the other side. So the intensity on a CT scan has to do with how much X-ray gets absorbed. So hopefully I'm windowing leveling these good so you can see the bone density here, right? So bone absorbs the most. CSF absorbs the least amount of X-ray, so it appears brighter. And then there's a mixture in between. You can see gray matter and white matter absorb nearly the same amount. This is chronic ischemia. There's more edema, fewer cells, so it's closer to CSF and it looks a little bit darker. When a person has a hemorrhage, it appears somewhere between the bone density and the density of the tissue on here, and you can see the hemorrhage, right? Not a whole lot of information in here, but there are ways to get better information out of CT, and this is after injecting a contrast agent that's iodine, and it absorbs X-ray higher than blood. And you can see the vasculature as we go up into the brain, right? So this is the middle, the internal carotid, and then you turn into the middle cerebral artery and all the vessels of the middle cerebral artery here, right? And as I move inferior, you can see the 2 vertebral arteries, the carotid artery here, and it's sort of hard to visualize, right? So I'm going to put in a 3D rendering, surface rendering, and let's walk through this a little bit. You guys, have any of you had you're not going to raise your hands, but have any of you had anatomy yet? How many people go into med school? Anyone? All PhDs? Oh my gosh, that's great. My daughter was thinking of med school. I'm very happy she's getting her PhD. So, my older daughter. Is that showing up? So this is a surface rendering of a higher resolution CT, and you can sort of see the patient, right? You can see the cannula in the patient's nose for the oxygen that's being provided. As I adjust this, so now I can start seeing the bone. And it's the same CT I just had up there. And if I zoom in a bit, I'm going to see if I can move this up a bit. Let's see if I can get a contrast a little bit better so you can see the vasculature. All right, so now I got the vasculature appearing a little bit different than the bone. And can you guys see the vessel here? Anybody know what this is? Carotid, yeah, it's a common carotid. The common carotid artery, and I'm an engineer, so give me a break on this, bifurcates into an internal and external carotid artery. And so you can see the internal carotid artery, the external feeding the outside. The internal carotid artery is here. And what we're seeing, and do you know what this is? Has the density of bone, but obviously there's no reason to have a bone next to the bifurcation of the carotid artery. It's calcium. It's atherosclerosis, and the reason it forms here is because of turbulent flow as it bifurcates, and because you eat a lot of Big Macs and other things you shouldn't be doing. And so it stenoses, and this is one of the causes of stroke, right? This thing becomes, there's a plaque in here, it's a calcified plaque, hopefully it's not an active inflamed plaque, and eventually the cap on this may rupture. And when this ruptures, it's one of the reasons people have stroke, because it throws a clot, and it throws crap and fat and calcium, and it starts moving up the carotid artery here, and it gets thinner and thinner. So just while I'm down here, you can see a couple other, here's the carotid artery on the other side, right? A little bit of calcium there. As you get older, you start to get calcium in all your vessels. And you can see the other two main arteries that feed the brain, the vertebral artery that comes up and it sort of interdigitates with the spine here. And on the other side, because this patient's a little bit older, there's a vertebral artery as well, and they come up. And this one's hypoplastic because of aging, and you don't need both of them necessarily because they rejoin up here and form the basilar artery. Is this interesting at all to be able to see this sort of in 3D? And I'm going to zoom in and cut into the brain or the skull. And if I can adjust this a little bit, now you can see down into the spine. And if I can just window and level this well, here's the hypoplastic vertebral artery, here's the other vertebral artery, and it comes up and it feeds the basilar artery right here that's in front of your pons and brainstem. And this is at the level of the circle of Willis. And the circle of Willis is formed, the internal carotid comes up here. This is the A1 segment of the anterior cerebral artery, the ACOM, the communicating artery, the A1 segment of the other side, and then it forms into the PCOM that goes over to here and hopefully connects to the basilar. In this individual, there should be a communicating artery between here and here. There may be one that we're not able to pick up because it's not filling, but on this side, the patient doesn't have a communicating artery, and the posterior circulation, which feeds the cerebellum, is fed off the carotid artery. So if this person occludes this area, not only do they take out the middle cerebral artery, but they take out the posterior circulation as well in this individual. So we've got great imaging of the vessels. We're able to see specific areas in the vasculature, but we still can't see the brain, right? So we can't definitively decide whether or not, based on objective evidence, if this patient's having a stroke. It's based on symptoms, and that's really the only thing that matters from the standpoint of both the patient's well-being, in a sense, the diagnosis and how it's currently thought of from a clinician's perspective to stratify them, and what happens to them. But here's what we get if we image them. So now when I look at that scan, again, left is right, right is left, and it's as if the patient's laying in the magnet and you're looking at them from their feet up, and I'm at the level of the orbits here, right? And you guys are used to looking at these roughly, so you can see the eyes, you can see the sinus here. And this is artifact because of susceptibility on the diffusion image, so it causes signal pileup. And then as I move up more superiorly, a couple things I see. There's like a little hole there. There's a hole here from the aged patient. I can see the ischemia, and this has a low diffusion coefficient. I'm not going to go through that on this scan. But very subtly, the whole territory is involved over here. And so let me make sure I've got the right one. That's not the right one. Here's the baseline. There, it's a little more obvious there. Now you can see the insula is involved. I sort of gave away the ending there. Very subtly here. If I pull up the GRE, you can see the dilated vessels that I mentioned before. So I know which hemisphere the stroke is in. I know roughly how large it is. This is the FLAIR T2 hyperintense vessel, so I know this collateralization coming from blood flow around the clot through the leptomeningeal collaterals on the surface. And here's where the thrombus is, right here, again, a proximal thrombus. And more importantly, I can see the vascular territory that's evolved by the perfusion imaging. And so this person, despite having very subtle cellular depolarization at this time point, having a core of the lesion that's fairly small, has an awful lot of territory that's risk and is an objective diagnosis. So this patient may be clinically fairly mild, but there's a lot to lose. Does that make sense roughly? Great. Yeah? Okay. So now here comes the problem. That's where we were 20 years ago. We had CTs of stroke patients, and it was based on clinical diagnosis. You leap forward 20 years to the war in Afghanistan and Iraq, and these patients are coming back that are clearly symptomatic. People who have concussion, mild TBI, are clearly symptomatic. But these symptoms that they present with often overlap other constellations of symptoms in patients that may not have organic injury to their brain. They may have psychological deficits or psychological injury. And yes, I know there should be some way to sort of reconcile the differences between what may be injury to the structures and the chemical function of the brain and what we currently think of about psychiatric disorders. But then there's a pragmatic aspect, which is we have somebody who's symptomatic, the CT is negative. What do we do about this? And this is a fundamental problem with stroke back 20 some odd years ago, which prevented us from moving forward with therapies. And it is still the fundamental problem with mild TBI. The majority of these patients are imaging negative on CT scan. So does anybody want to guess what's the physical ailment with this patient? Psychiatric disorder? Did he have a stroke? Right? Is this severe traumatic brain injury? Well, the obvious. Think about what the obvious is here. And it's easy to appreciate what this individual and appreciate the deficits that he may have because of his injury. And what's even better is you can appreciate the compensation that he has for this. So if you look at this without really thinking deeply, he's developed a faculty that most of us, I mean, I can't paint with my feet. I don't know if anyone else wants to admit they can paint with their feet. But he's able to paint with his feet, and that's incredible, right? So he's compensated. And it's probably not because of brain injury, probably because he doesn't have any arms. So it's very easy to sort of relate to that and appreciate him for what he's been able to accomplish. When the brain is injured, particularly in TBI, then it becomes much harder. So if somebody's doing neuropsych testing and may have not seen the patients yet, but I have one patient that calls us, and I'm not a physician, and she calls me probably monthly simply to talk about her deficits. And it's hard to separate what is her injury from the pot that she smokes because she thinks it's helping her, from alcohol and some of the other substance abuse that she has gone through that she knows isn't helping her but isn't able to stop, from things that may be psychological injury from her and how this occurred when she was a child. So it's really, and I think a lot of patients with TBI are underappreciated, and neurologists haven't been terribly interested until recently, until the funding, because these are extremely difficult patients to deal with, right? And it shouldn't be surprising. This should have been very aware. I mean, we should be aware of this going into the problem because of other research that's gone a long time ago that we've connected behavior to specific areas in the brain. So you injure your frontal lobe, what happens? Your personality changes. It makes a lot of sense, right? And we know this. I think the most famous case is Phineas Gage. And then we fast forward from our understanding of Phineas Gage, and we have sports, right? Football and hockey, and this is the NFL. I'm a Boston fan, and NHL playoffs in 2011 get hit hard enough that the players down on the ground invisibly on television seizing. And this, to me, signals that there's possibly mechanical injury in the brain, and that it shouldn't be a surprise that years down the road that patients that experience this mechanical injury are likely to have long-lasting repercussions, right? It's how do we identify those individuals in a way that separates the environmental concerns with substance abuse and the risk factors that we have in stroke, may be hypertension, hyperlipidemia, high levels of cholesterol, and other factors in our life choices that lead us to atherosclerosis as we get older from other risk factors that happen in the population that receive TBI, and they may be innocuous, like playing sports. And they may be good, like playing sports. You don't want to take away sports from them. And then some of these may be confounded by other comorbidities, such as pre-existing mental health disorders, anxiety, schizophrenia. So these are two scans. They're both of me. I'm not a schizophrenic, but, but if you look at these and you try to identify a focal area in the brain, you can't. So there are types of imaging approaches that we can use to try to separate cohorts of patients. Mental health has been doing, some fantastic work in that direction, but it's not the kind of things that we're interested in. And one of the issues is, if we already know the classification that this patient is schizophrenic and this patient is not, then it's a different type of question, not one of diagnosis of stratification or classifying them, but it's one about how we may be able to find imaging markers that reflect the underlying pathology, underlying disease, and that we may be able to modify those underlying differences, whether it's functional activation-based studies, or diffusion tensor imaging. And Dr. Insall now is no longer the director of NIMH. Is that right? Yes. Does anybody know an NIMH? Anyway, so the NIMH had a push in recent years to move away from clinical diagnosis, from very subjective clinical, to something that's more objective. And this is, I think, fantastic. And groups working on things like functional activation, studying resting state functional connectivity, or DTI, if we can start to phrase questions in ways where we can stratify patients and put them in boxes, where you come in with somebody that may have schizophrenia, but you're not certain, and somebody who definitely has schizophrenia, and then we can place these guys in particular boxes, and we can start to understand in a more objective way of stratifying patients. So instead of treating patients based on symptoms, symptom-based classification, in most stroke patients that we have a therapy for right now, that's a relatively easy thing to do, because they were fine, then they had a sudden onset of symptoms, and the symptoms are focal, and we know how those symptoms relate to a particular area in the brain. But for the majority of patients, stroke patients, that's much more difficult, and it's nearly impossible in the TBI population, aside from the more severe. So these symptom-based classifications, a patient that has hemorrhage are more likely to be nauseous. A patient that has sudden onset of aphasia is somebody we should be thinking about as having a stroke. Replace those with imaging-based classifications where it's ischemic hemorrhagic. And this is a little bit of an oversimplification. And then use things like blood to look at the gene expression levels, or how we can better understand these classifications and how that relates to the human genome. This is the way we thought about it in 1992. And this is some throwback to 1992. And this is how you guys, hopefully, if you head into science and medicine, will be standing here one day and saying, I wish I thought about this differently. Or maybe you get it right the first time through. But we thought we had it right the first time through. And unfortunately, we've spent 20 years working on this, trying to find imaging markers, right? You say, I'd like a biomarker. And in the end, it sort of doesn't matter. I don't believe that, so I'm being sort of a little, facetious here. It is important. It's just maybe for a small group of patients doesn't matter, because we have in stroke now a therapy that's very effective. It's this clot removal. You go in mechanically, and it shows that in very gross terms, we save people. There's fewer people that head to death, or to 5. We're struggling with this internally as a group right now, because in translating this from the clinical trials to our practice, or how we do this, we're not experiencing the same thing. We're finding a much higher rate of death and severe disability than the trials, which were sponsored, again, by pharmaceutical or by device manufacturers, have reflected. And in these trials, a high proportion of patients went on from a mild and moderate disability to either no symptoms at all, or just mild disability. So it's a shift in this clinical scale. Again, 6 is dead, 0 is no symptoms in the control population, to those that were treated with the intervention. So one of the disappointments in stroke was we went through trials that were based on particularly neuroprotective trials, that were based on inclusion and symptoms. And this is being repeated in other diseases as well, if it's a subjective, and we spend hundreds of millions of dollars. And many of these drugs may never even made it across the blood-brain barrier and into the brain, and many of them may have not had any effect, because the primary issue in stroke is if that clot isn't removed, blood flow is not reestablished. It doesn't matter how long we protect the brain. Without constant flow of blood and glucose and removal of waste, the tissue is going to die. So we're repeating this now in TBI. And these trials, for instance, for acetylcholine down here, or progesterone, which had great potential efficacy based on the animal studies, are failing at the costs of about $20 million a trial. So we, think about this from objective. We have to move forward in TBI, but we're repeating the same, and this is now 20 years after those early stroke trials, the same mistakes we made. In 2013, these endovascular treatment trials failed. In 2015, with the new types of devices, they look like stent retrievers. They look like I don't know how to describe it. They're a mesh. They get inserted into the clot, they expand, and then they literally get pulled out. They were successful. Do you guys know what number needed to treat means? Have you had this? So again, it's hard to translate maybe for basic scientists, and again, I'm coming from a basic scientist and imager standpoint, but it's critically important. Not every therapy is going to help every patient. It turns out defibrillation, the number needed to treat for somebody that is in cardiac arrest, you have to treat 2.5 patients in order to save one. Right. So that's remarkable. This is as good as it gets. These new endovascular therapies in stroke, the number needed to treat is between 3 and 4, which is phenomenal. Thrombolytic, the number needed to treat was 20. So we have to treat 20 people in order to help one, to improve one. For screening for mammography, the feeling is generalized screening, the number needed to treat to help one person to reduce one incidence of breast cancer is infinity. Does that make sense roughly? So you guys know Conan? No. What's best in life, Conan? Is it the symptoms? Because I just made an argument of how critical that is. We're showing a phenomenal impact. Or is it biology? When we look at our population again in stroke, we're talking about 1,000 patients over a 9-month period come into 2 of our hospitals, and then we start going down there. Of the patients that present with symptoms, only 2/3 of them have a stroke. Of those that have a stroke, only the 86 is considered fairly young in the stroke population. A smaller fraction are young, and those that are older, it's hard to prevent their progression. It's not futile, but it gets much more difficult as you get over 80. And those that have a disabling deficit, meaning these guys, the difference between these are very mild. So this is analogous to the mild TBI population. Of those, how many come in within 24 hours where we can really have an impact before the tissue dies? Look at the numbers. Now you say this is where we're at with the symptom-based approach. And now we start looking and you say, of the 166, how many of them are able to get an MRI? And there's reasons patients can't. How many of them had a perfusion deficit, like that stereotypical patients I've shown you, who have a lesion that's large? And how many of those have a mismatch between the size of the lesion that's abnormally perfused and the diffusion where the injury is most severe? And we get down to 40 of about 1,000. So either you say, this other 960 patients are uninteresting, right? And you focus only on these, or you try to understand how we can address stroke in this population as well. So I'm going to focus on that 40 patients. This is, I forgot I had a picture so you guys can see exactly what it looks like. This is a stent retriever. This is the clot. It's a cartoon of the device being threaded up into the middle cerebral artery through the internal carotid artery. And this is a person's thumb or finger pointer or a little ruler. And this is the clot that's retrieved in one of our patients from endovascular therapy. And so the way this happens is the patient comes in, they get imaged with MR or CT. We know they have a large vessel occlusion, as it's called. And then we quickly rush them to the interventional suite. And a puncture is made in the groin right about here. And the catheter is fed up through the groin and up into the brain under fluoroscopy. And it's threaded under X-ray fluoroscopy until you reach up there, and then a little devices like this is extended and it's pulled out. So I'm just going to show you what that looks like. So are most of you guys trained, sorry, not to go off topic, but are most of you guys trained in like engineering, physics? What's the background? Psychology? psychology yet? So you go to a medical meeting. That's probably one of the good reasons to go into the medical field of medical research. You get, the poster sessions has cheese and it's fantastic, all this. You go to a physics meeting and you get like 2 crackers and cheese to split them out, 500 physicists that are, so anyways. Okay, back to the topic, and now this thing's up. So this is the, again, to orient you, internal carotids here, or common carotids here, the bulb, and then this is the internal carotid. And you can see the vessel there, and it's been filmed. And what you're seeing, if you can see this little catheter that's feeding up there, you'll see it extend right up in here in the middle cerebral artery. And remember, this is a shadow, right, from endovascular, and now it's extending out here. And they're now touching the clot. They're extending in it, it's grabbing, and then there'll be a little bit of tension. Let's see if it shows. And then it gets snapped, and it gets pulled out right there. And that's what they get to guide them in removing this clot. And then after the clot is extracted, then you can see they inject the iodinated contrast agent, and you can better visualize the middle cerebral artery, all the small arteries, the vasculature. What's really cool, I mean, I love these scans, right? Because you can see it go from the arterial side to the venous side, and you can see the superior sagittal sinus, and then the lateral sinus and the draining veins that go into the, what is that? That drains out of the neck? Jugular. So now the whole brain's perfused. And I'll give you another view from the sagittal, and you can see the patient's nose is down here, the eyes are here, and you can see the vessels fill. And for anyone interested in fMRI, you can see the time frame. Each one of these is about a second or so. So you go from artery, fills all the small capillaries, and then you're draining into the veins. Pretty cool? And then the outcome of this patient, which I gave away earlier, is that that large lesion that we saw at baseline, I'll pull it up side by side, right here, and it's very subtle, left behind only this small infarction. And it's still on DWI, but if you follow this patient for a period of time, you can see this is the insula. There's a little injury to the insula, and this is edema or on the FLAIR image. There's some injury out here to the cortex and injury in the deep structures. And so we know what we've accomplished, I think, by having this imaging. Cool? Makes sense? So right now, in the current state with MRI and stroke, or endovascular and stroke, the standard is CT. We're unusual that we're still going to MR, but we're trying hard to keep that. But there's a huge pressure right now that every minute matters, and MRI takes longer. And we don't need MRI. We understand what's happened to these patients clinically, but this is a really fantastic outcome. What we used to think was the diffusion lesion, the low ADC, that area that was depolarized and destined to infarction, we're now finding we can completely reverse. So it's a transient depolarization. So it's not just the tissue that has the abnormal perfusion. We're now saving what we thought before was the core. And these patients, somebody who would have headed to a modified Rankin scale of 4, 5, or 6 dead, in a number of them, they're walking out of the hospital in a day or two. So it has a huge impact, and this was not the way it was when we started 20 years ago. So we'll talk about mild TBI briefly. Another change, and I love this little guinea pig. Are these models relevant to humans? Is this what we're trying to do, is to model TBI by exposing, taking a mouse or rat, exposing their skull, removing their skull, then having, an impact hit the brain, the exposed brain, dent the brain, cause a hole in the brain? It's not what is representative of the majority of TBI patients. It does represent some, but not the majority of the patients that we're most interested in. Nonetheless, there's evidence from these models, and this really drove it, that one of the primary phenotypes, endophenotypes in TBI, is a mechanical injury to the axons. And that drove then sort of this excitement about DTI and be able to see changes. If diffusion tensor imaging is a way to measure diffusion, and diffusion is progressing in an oriented fashion in the brain, then you shear the axons, you injure the axons. Of course, we should see a change in diffusion, and of course, we should see a change in the amount of anisotropy that's there. And this hit a lot of excitement and funded a lot of the work, which is good. And it also possibly helps us address other questions, which is what is relevant to the humans that we're seeing, at least in the emergency department personnel that we are, patients that we see. And we think this is relative to the military population, because in the military population, the majority of the injuries are very analogous to, except they're young, healthy, you know, men and women that are about your age, rather than the general population that comes into Suburban Hospital, Washington Hospital Center. But we see injury in these individuals, and we see injury that are focal, and it was not what we expected. It was not at all what we were going after. And so it's led us to this postulate in mild traumatic brain injury that the primary mechanism of injury is not necessarily direct injury to the brain and to the axons, but it's injury to the vasculature and to the meninges and that surround the brain. And so this is the model, and I'll go through this a little bit and we'll stop partway into this. This is the model that you sort of can picture that's put in popular science or the media, that the brain is somehow sitting in a can, right? And then the can is accelerated against something like a wall or a car. And because of that, the brain bounces up against the front and then bounces back and hits the back of the brain. And that causes a contusion, or it causes mechanical forces in there. Does that make sense to you guys? Is that what you guys have heard? Is there a real can? Is there space? There aren't springs like this. The brain is, if you've looked inside, or at least in imaging, or actually looked at a cadaver or a live patient, there isn't a whole lot of space in here for the brain to move. But the brain has mass, and it does deform. But the better way, I think, to think about this is it's an elastic that can be inelastic deformation as well that causes the tissue to tear or to break. But a lot of this is either by compressional stresses or shear stresses in the brain. And this isn't ours, this is somebody else's, but it's a great video. If you can watch a wave propagate, and when it's turning red, it's in compression, and when it's turning blue, it's under pressure. And then this is the shear stress that goes through. So first thing you notice is there's a compression at the top, and then as the wave, acoustic wave, propagates through the brain, there's an under pressure that happens on the opposite side, and that under pressure causes the brain to sort of withdraw from this side of the skull. And in the shearing, it's a little bit different. You can see where the peak of the shearing forces are. It tends to be at discordances in the properties of the tissue, such as it's occurring at the junction between the tissue and the ventricles, or in the depths of the sulci, where CSF and the tissue itself has a different elastic property, right? Pretty cool to sort of visualize this in a sense. So these are a lot more complicated, these structures. And first thing we forget, and most people doing imaging, is that the brain is not sitting in a can. It's separated from the skull by the meninges. And one of the main structures of meninges is this falx, which is a very tent-like structure. It's sort of tight. If you open it up, it's like a plastic, as rigid as a pretty good, strong plastic bag. And the brain is separated, the two hemispheres, by the falx. And the falx, at the top of it, the dura reflects in, and I'll show you a better picture of it once I get off this view. And it forms the structure that drains most of the blood from the more superior sagittal sinus, superior structures, and then other venous structures here. So there's the falx, there's the tentorium, and the brain is sitting separated by these structures. If one hemisphere is injured and it starts to swell, what happens? Where does the brain go? It can't cross hemispheres, right? Because of this tight structure here. It starts to squish like toothpaste down through this little opening here, right where the corpus callosum goes, right? Where one of the areas that most people in TBI are studying, because a lot of the fibers cross right under the falx and near the tentorium. And then the brain squishes out and heads down into your spine. So as edema begins to form, the brain starts to head in this direction. And if there's so much edema that it pushes enough brain down here, it stops CSF from flowing, and then intracranial pressure increases, and more brain squishes down, and then blood flow stops to the brain in the most severe cases. So I'm going to look at this structure up here, right in the sagittal sinus. And so just to orient you, here's white matter, here's gray matter. We don't think a lot about this, but this is the glial limitins here, and the peel surface is sort of represented in purple. And then there's arachnoid trabecula, and then this is the arachnoid membrane. And you can see outside the arachnoid membrane are two layers of dura matter, which are thick. One of them adheres to the skull. The other one adheres and is a cellular boundary layer between the dura and the arachnoid layer that's right here. So when somebody bleeds and you hear about subarachnoid hemorrhage, it's bleeding of these vessels or some vessel in the subarachnoid space, the peel vessels, into this subarachnoid space, which is filled with CSF. And CSF can be drained, and bad things, or not just normal things, get drained into the venous drainage structures through these arachnoid trabeculations, which are, again, stuck into a space that has adherence to the skull. So now if you picture the brain moving, tethered to this space by arachnoid trabeculations, the arachnoid granulations, the villi, and these vascular structures, it makes a lot of sense intuitively that they're in one of the most fragile regions in the brain and they're going to be injured, right? So this is a picture of the meninges from an MRI, and I'm going to pause partway through so you can see this. In the coronal view, and it's post-contrast, and if I can hit the pause button quick enough, let's see. You can see these structures right here, the superior sagittal sinus. These are bridging veins that head down, right? And they head into the depths of the sulci. You can actually see some of the arachnoid structure in there, right? So now changes the picture. The brain moves, and these little vascular structures that are tethering the brain get stretched. And the dura itself can't move. The arachnoid membrane that's sitting there also gets sheared and gets pulled off. Make sense? So this is what a real brain looks like from one of our patients. And so what you're seeing, the fuzzy stuff here, is the arachnoid membrane that's easily removed from the dura. Here you can see the dura, the vasculature of the dura, a couple of those bridging veins that are still intact. This patient had a large, for lack of a better word, contusion, and then because of the swelling of the brain to stop the herniation, the skull gets removed and the brain swells outside of the skull. The skull gets held in the abdomen until the swelling goes down and the skull gets placed back on the person, and they recover, hopefully, or die. In this case, we have their brain. And then so you can see just a visual of those vascular structures heading down and penetrating in, and this is where it starts to get interesting for people thinking about brain function, functional activation. There's these glial cells that surround and form the vasculature. So you have the parenchyma, you have the capillary, the endothelium, the neurovascular unit, and then there's the basal lamina, which is between these two structures, which contains CSF. And it's hard to figure out where that perivascular space, basal lamina, ends and these larger Virchow-Robin space, perivascular space, begin. But CSF has moved along these spaces and is in part used to clear things like amyloid beta and tau from the brain, for instance, in times of injury. Okay, cool. So it also contains the inflammatory cells in the brain, in these meningeal structures, and this is an erythrocyte in the meninges, and resident macrophages attacking the erythrocyte to be able to engulf it and then protect the brain from it. So it's a very complex structure, and we see injury in the TBI population in a large fraction of these patients in a couple different ways. We can see subarachnoid hemorrhage, subdural hemorrhage, bleeding between the dura and the arachnoid membrane. We see injury to the structures of the brain that look like, just like we see in stroke. It's a bright signal on DWI, a low signal on ADC, which suggests cytotoxic edema and cellular depolarization. But these guys tend to be in the same vicinity of these things here, which are traumatic microbleeds. They're thought to be associated with shearing injury. We're finding that they're more likely related to these bridging veins that are tethered being injured and blood being extravasated, and then macrophages coming in and eating up the blood. And then this is a post-contrast flare, and this is the falx lighting up. We find that in 1 out of 2 mild TBI patients that present to the emergency room, we see the arachnoid membrane sheared off the dura, and that space fills with fluid. It's hard to see the fluid until we give a contrast agent, and then the contrast agent gets into that space, so we see the falx injured. So I'm running out of time. I want to show you just a couple more things in here. particularly this meningeal injury, to really drive home the point it's something we weren't looking for. So in stroke, when we give contrast agent to patients, the blood-brain barrier, you guys are aware the blood-brain barrier usually separates the whatever's in the vasculature from the parenchyma itself. Usually contrast agent stays within the vasculature, but in aged patients or patients that have a stroke, the ischemia results in blood-brain barrier disruption, and that contrast agent extravasates and gets out into the CSF space. So we can see this in a large fraction of patients, blood-brain barrier disruption, basically. So we went into the TBI population with some anecdotal evidence from a few patients. We were expecting to see evidence of blood-brain barrier disruption, just like we see in stroke, and we haven't found this. So again, sort of serendipity is while we were looking at this enhancement in the meninges began to appear, and we started to study this. And this is, it ends up occupying a space in the falx, the tentorium. You can see it here along the convexity. It appears in different levels of severity. Some of these things are space occupying. Others are very, very mild and hard to find. It's split in our arbitrary grading system by a factor, by about 1/3, and we're now up to about 500 patients and about 250. So this goes up almost an order of magnitude. It disappears in about 1/3 of them by day 4, and about 2/3 of them subacutely. The meninges are innervated, right? So patients that have injury to the meninges end up having headache, nausea, vomiting. So we think one of the primary mechanisms of injury and the symptoms that come off haven't at all to do with injury to brain, but has to do with injury to these vascular structures. Make sense? This is a T2 flare image in somebody that has mild TBI, if I can just get back up to the top, based on clinical severity. And you can see, if I let it go around, this is the superficial contusion on the patient's back of the head. And this is somebody that we've imaged, and again, you can see the superficial contusion on the scalp of this individual, and then after giving contrast agent, it enhances the frontal lobes and the falx here. And so this is just an example of one of those patients imaged acutely, and then sort of a dynamic change where we see the falx, the meninges enhance acutely, and then over time it starts to resolve. But as it resolves, you can see it's space occupying and the brain sort of moves. And so we're still working on trying to figure out how we can relate this to clinical outcome in these patients, because if you go back to the sort of the point I was trying to make with the stroke patients is, yeah, we can find some things, but if we can't impact clinical care in the end, it's not as important. So we're trying to relate this to clinical outcome. And then just one more quick, let me pull up a slide just to show you where we are with the vascular injury. I sort of made a couple, gave you a couple examples and teasers. All right. This is a mild TBI patient. This is somebody that was from Maryland, University of Maryland. It's a young kid that was in, 21-year-old engineering student, I think, that was symptomatic. And these are those, the extravasation, we think, of the blood into the perivascular spaces. I'm going to just skip ahead to a patient that we had that died, the one brain I was showing you there. And when we extract the brain, this is what it looks like imaged at 7 Tesla, the brain held in somebody's hand. And then these are the regions that have been co-localized in regions of interest overlaid over pearl stain, iron stain, so we can see the areas that appeared on MRI, and this is what the underlying structures look like. And just sort of an illustration of where the great white matter junction is. And so in these areas where we see injured vasculature, we also see injured neurons and cell death and atrophy. And we're still working on this, trying to relate, again, this acute injury to how it progresses over time and what it means for the patient. And just in interest of time, I'm going to stop here. I know I went through a lot of things fast. I wasn't sure what you guys would be interested in. That's it. Any questions, thoughts, interest? Anything confusing? After this, are you interested in stroke? No? TBI? Maybe? TBI, there's a group mostly interested in TBI? Yeah, love to talk more. If you have interest, come see. The group is really strong. I've really undersold it here. In order to do these things, it takes a huge effort from a lot of different expertise, running from the most clinical side to people that are very technically oriented. And you know, it's one of the things I really like about being at the NIH. It adds, Miriam, who's our coordinator on the stroke side, used to be on the TBI side, is in the audience here. It's one of the most exciting things, but it also adds one of the biggest challenges, is trying to figure out how to relate your interest to somebody who has a very different set of interests and focused on the care of the patient. I encourage you to bridge those areas, because I think it's where the most reward is as you go forward in your career. So that's it. Thank you very much. And thanks for coming on a really beautiful Friday afternoon. I thought I'd be here alone. Thanks, guys.